and welcome to the Davies Use Case webinar being presented by Lāna Community Health Center on telehealth. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. Davies Award recognizes outstanding achievements of organizations from around the world who have utilized health information technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. So it's my pleasure to welcome our two speakers today, Dr. Joe Humphrey and Dr. Corey Takasui. And I will turn the presentation over to them, let them introduce themselves, and you all can start your presentation after you make your introduction. Thank you, and welcome. Okay, I started the recording again.
Thank you, Arnold, and it's truly an honor to be able to do this presentation and share our experience with telehealth. My name is Dr. Joe Humphrey, and I'm the Medical Director and the Director of Quality at the Lāna Community Health Center. And with me is Dr. Corey Takasui, who's our behavioral health specialist, and will be sharing part of the presentation. To start with, information about our community health center. We were a fairly new health center, started in 2008 when we first saw our first patients, and it is a federally qualified health center. We currently provide health care to approximately 60% of the population on the Lāna Community Health Center, and provides holistic integrated medical care, dental care, and behavioral health services. The total number of our employees is approximately 40, and most of them are full-time, and we focus on hiring people from our local community. Our professional staff includes 2 full-time nurse practitioners. Myself as medical director, I have about 25% FTE. For clinical, and we have 2 full-time psychologists and our dental team. And currently we see approximately 2,000 unduplicated patients, and we have 7,500 visits a year. Yeah, the island of Lāna has a population of a little over 3,000, and it has a plantation history. The island was known as the Pineapple Island and had the largest pineapple plantation in the world until they closed pineapple operations down in approximately 1993. We have a very diverse population of Asian and Hawaiian and Pacific Islanders primarily. 40% of the residents are Filipino, reflecting the immigration from the Philippines to harvest pineapples. Being a plantation, the island has only 30 miles of paved road, and it does feature some amazing hikes, gorgeous beaches, and of course fresh air. The current economy is really driven by the hotel hospitality industry, with 2 hotels on island, 1 currently open. And in this presentation, we provide a variety of different telehealth services. I want to initially focus on our video teleconferencing, which we use a Zoom platform. Then we'll go through the store and forward services we provide and finish with remote monitoring. One of the aspects of telehealth is that we also have a fairly advanced integrated health information technology, which we use to complement our telehealth services. And so that will be presented also. At this time, I want to turn over to Dr. Takasui, who's going to be highlighting our behavioral health integration with our primary care.
Hello, everyone. Yes, so basically, we've been integrated with primary care and behavioral health since probably about 2012, and have now extended beyond that to dental, our dental program as well, and through our community health workers. But about 80% of mild to moderate behavioral health conditions are managed in the primary care setting. Often the issue is that rural communities lack the resources to effectively manage the range of cases in the community. So to assist with that, we've kind of looked at, well, how do we do better screenings, detection of behavioral health issues, and how do we manage patients who have behavioral health conditions? So we started by implementing a screener and then using the model of SBIRT, which is screening, brief intervention, and referral to treatment. And we have implemented by creating a screener that assesses depression, anxiety, trauma, alcohol use, and then an additional separate tobacco screener. What we do is we have each of the departments, so it goes health center wide. We have it implemented in primary care, behavioral health, dental, optometry, and then through community health worker visits in the community. We have them implement the screener, and if there's positive scores, the staff are trained in doing some brief interventions, and then if there's kind of extreme positive scores, then they do a referral to either the primary care provider or the behavioral health specialist. And then if there's patients that are identified as having a little bit more severe or complex conditions and maybe needing further assessment that is beyond the behavioral health specialist capabilities or medication management or consultation, we then do vertical integration with psychiatry through the University of Hawaii Department of Psychiatry. And through them, we are able to get phone consultations, video teleconference consultations, and also education on special topics that the LCHC staff might have questions on. And then how this works is it allows us to get timely access to a psychiatrist for crisis management and brief interventions without the patient having to go off island to receive these services. So how does Zoom work, as well as the vertical integration? Well, first, either the medical provider or the behavioral health specialist maybe identifies that a patient has a more severe or complex condition and is needing a little bit more accurate diagnosis and assessment or medication management because either they're not on medications or the current medications that they're on aren't quite working effectively. So then a consultation is made between the provider who is referring and the psychiatrist and discuss whether or not the psychiatrist needs to see the patient or if there's just a brief intervention that can be given to the provider to use during their sessions. If their referral is needed to the psychiatrist, basically an appointment is set up using the Zoom program, and during the session, either the referring primary care provider or the behavioral health specialist is in the room with the patient while the psychiatrist is on the the video screen. Also included in this vertical integration is we have a behavioral health team meetings every month, and then every other month with the psychiatry team. And basically, during these meetings, we discuss care coordination, and also the Department of Psychiatry at UH also provides the LCH staff with special topics, things that we might be interested in. For example, psychotropic medication, substance abuse, chronic pain, elder care, and chronic disease management. So it does serve to provide education to the staff as well. We do get brief telephone consultation within 24 hours for urgent matters or for medication management issues. LCHC provides the technology, meaning we've acquired the Zoom license, and we do the scheduling for the providers or the psychologists with the psychiatrist. And basically how this works is the medication recommendations are made from the psychiatrist to the medical providers, and from there the LCHC medical providers are the ones that prescribe the medication. The result is basically a broader spectrum of psychotropic medications being used, monitoring for side effects, and appropriate titration and adjustment of doses. And lastly, at times we look at using a combination of medication. So I want to talk a little bit more about the stress questionnaire. What we mean by stress questionnaire beyond depression screening is that our patient stress questionnaire is comprised of a combination of surveys. As I mentioned before, it addresses depression, anxiety, trauma, and alcohol use. And then in addition, there's a separate tobacco screener that we also administer. So basically, when we do the survey, it's implemented in CDMP's survey portal, which either allows the patient to complete the survey online through tablets, or the patient will work with a medical assistant, dental assistant, community health worker, or behavioral health provider to complete the survey. Once the questionnaire is implemented into the CDMP portal, it's automatically scored in CDMP, and the depression score is then exported to Bridget IT for UDS depression screening reporting. The UDS reporting is completed using Bridget. Again, as I mentioned before, the medical assistants, the dental assistants, and the community health workers, they're trained in administering the screener, but they're also trained in doing brief intervention for tobacco and alcohol use. For more extreme positive scores, they're also trained to then do a referral to either the primary care provider or the behavioral health provider, or even to do a warm handoff with the behavioral health providers if the behavioral health provider is available. The stress questionnaire is completed annually and with all new patients, and then also sometimes with certain providers they feel like it might need to be done sooner, especially if the patient is exhibiting visual symptoms, and so we can also do it earlier than a year as well. And then it's tracked in ECW with an electronic copy of the full stress questionnaire stored as a document in the ECW portal. So this is just an example of the workflow that we use for the stress questionnaire. Again, it starts off with the stress questionnaire being completed. If there's a positive score, yes or no. If it's yes, there's a short, brief intervention, and the person administering the screener also then informs the provider if there was a positive score. If there's a positive score for anxiety or depression, the person administering the screener is either going to report to primary care provider who will assess the severity, or they'll also do a behavioral health referral. So kind of, they've been trained on how to kind of do the workflow for the screener, whether or not to make a brief intervention or whether or not to make a referral to treatment. And so just to give you a little bit of data of the patients that we've seen since we've implemented this. We've worked with about 25 patients who've gotten the referral to psychiatry, 48% male, 52% female. And with regards to ethnic background race, about 44% were white, 32% Native Hawaiian, 12% Asian, 8% Hispanic, and 4% African American. Now, these numbers don't necessarily reflect the population numbers that we gave you. However, what happens with behavioral health is these are sort of the populations that might be willing to seek treatment. So it's kind of, it could be underreported for other ethnic backgrounds that aren't best represented by these percentages. Most patients, about 47% get one medication, 26% get 2 to 3, and 26% get about 3 or more medications prescribed. 2 of the participants that we've worked with so far were not prescribed medications. One, I know for sure that they were recommended a medication. However, because it was a child, the parents did not want to start the child on medication. And then primary mental health diagnoses that we've kind of referred to get better accurate assessment has been more neurodevelopmental disorders, about 32%, many of them primarily attention deficit disorders, and a couple autism spectrum disorders. And 20% report depression, 20% has been schizophrenia spectrum or other psychotic disorders, 8% bipolar, 8% anxiety, and then neurocognitive disorders at 4%. And then last but not least, for the collaboration with behavioral health integration, our current model with our vertical integration with psychiatry, we have published an article in the Hawaii Journal of Medicine and Public Health. So this is just the resource for you if you wanted to look further into that. I'm going to pass it over to Dr. Humphrey.
Yes, thank you very much, Corey. From a primary care standpoint, I just want to emphasize this access to care has substantially improved the quality of care. Previously, for medication management, most of the requirements have always fallen on the primary care provider, often my shoulders, and I have very little experience in complex psychotropic drugs. So this has been a major step forward. And part of it really has been the introduction of the Zoom telehealth platform. And our telehealth traditionally has been a hub-and-spoke model with the larger organizations, hospitals, and other institutions purchasing the software and providing the software to the rural communities with the scheduling and the coordination all done at that central location. Zoom is owned by the Lāna Community Health Center, and we actually provide the technology. So the hub is now the Rural Health Center, and we are able to basically provide technology to others to facilitate our access to care. It's important that it's cloud-based and agnostic communication devices, which makes it far easier to basically connect with other providers. And in our health center, why it's easily available in all of our exam rooms as well as in our administrative areas, and we actually can use it with tablets for home health care. It's clearly provided the access to psychiatry and facilitated the team meetings. We've also introduced it to new providers. Quite often we're using it for pre-op or post-op care with surgical subspecialties and other medical specialties where we've actually just asked them to bring devices to work and have their first experience with telehealth. And I would emphasize the other component that really has allowed this to happen is that we do not have a telehealth program. We do not have a telehealth coordinator. We do not have a telehealth schedule. That all of this is just integrated in, and all of our administrative and clinical staff are trained to use Zoom. I want to move forward to our store and forward services. And the first one introduced to Lāna Community Health Center was a JVN CDMP platform in 2009. Teleophthalmology is used for patients with diabetes to facilitate retinal examinations without an eye doctor appointment. And this basically works with our medical assistants being trained as imagers, and they schedule and take the images. LCHC is actually fortunate to have optometrist services twice a month. And for patients with diabetes that have visual impairment or some other eye problem, we refer to our optometrist. But the teleophthalmology is available around the year, around the clock. And patients that specifically need diabetic retinal exams now can have access at any time through teleophthalmology. And the CDMP is the platform we use to basically store and transfer the images to the reader who generates a standard report. And this, and next slide is essentially the graphics of the way it works. The imager takes seven images, which basically goes to CDMP, which is cloud-based. CDMP is integrated with our electronic health records, so there's clinical data presented along with the images that is transferred to our optometrist who is currently on Oahu, and they basically do the reading. It goes back into CDMP, and that then is reported back to the electronic health record as well as the provider. And we've the standard report is very valuable because it basically provides a standard methodology to report, which the primary care doctors understand. It also facilitates a significant amount of research because the metrics are all standard across the system. I would mention that this platform is the platform that is used in the Indian Health Service, who has a very extensive teleophthalmology program. So there has been a considerable interest in looking at the results from teleophthalmology. The second store and forward technology we have is teledermatology, which we initiated in 2013 using Direct Derm as our partner. The Direct Derm program is teledermatology services that primarily facilitate dermatology in Northern California, and we've been able to tap into that. Well, as you'd expect, we basically take photographs of the dermatological problem and complete a clinical information form on their webpage. The dermatologist that works with us closely does have a Hawaii license, and we've added credential to the health plan, so we actually can bill for the dermatology services. And we've had 39 dermatology consultations since we initiated in 2014. The third store and forward technology we're using, which has been very effective, is that being having a small population, why there are no deliveries and no available OB/GYN services on island, we do the prenatal care, and we've got our nurse practitioners that provide that service in coordination with the patient's obstetrician. Generally speaking, for normal pregnancies, there's 2 ultrasounds required, and for more complex pregnancies, often more than 2 ultrasounds required. Historically, these all had to be done off-island until we were able to secure an ultrasound machine and the technology to basically have the ultrasounds read at Kapiolani Women's and Children's Hospital. The StudyCast platform that does this is cloud-based, and so it's important because many of our women deliver at Kapiolani, and the ultrasounds are available at the time of delivery as well as all the reports. We do also do abdominal ultrasounds, and those are read actually at Maui Diagnostic Imaging using a PACS transfer system rather than the cloud-based system provided by StudyCast, as a radiologist wanted it actually on their server rather than cloud-based. So we've got 2 different technologies in regards to sending the ultrasound. And we currently average 8 to 12 studies per month. And I want to present how this really impacts patients' lives. And this fall, we had a patient who was 72 years old, female, who had presented with episodes of abdominal pain and a history of possible ulcer disease. When she was initially seen while she was treated with PPIs, which are an ulcer medication, hoping that would relieve her pain, she returned a week later, and she'd had relapsing abdominal pain that lasted for several hours with periods of minimal discomfort. Her physical examination showed epigastric and right upper quadrant pain. We were able to get an urgent ultrasound, and we identified a common duct stone on the ultrasound and drew laboratory tests to confirm that finding. And actually, with Lāna, we're far enough away from the lab that we have to send all of our labs off-island. So the next day, we got results back that really confirmed acute obstruction of the common duct. This facilitated our referral to Queens Medical Center, and also had a recognition that we didn't have to do air vac to get the patient off the island, that this is a relatively chronic condition and we could use commercial flights. It also facilitated getting her to bypass the emergency room and an extensive workup at Queens, because we had established the diagnosis and got the surgical consult much earlier than if we had not had the ultrasound. I'm going to transition now over to our remote monitoring. Our other case study is looking at our hypertension program and our home blood pressure monitoring that was established in 2014. Within the context of that, we also introduced remote monitoring for diabetes in 2017. This was facilitated by the one-touch Varios Flex meter being released, which is Bluetooth enabled, and so it allows us to build an interface from the meter to move data directly into CDMP. This is very important for our patients because 60% of patients with diabetes also have hypertension, and we're already on remote monitoring. And by bringing on the Bluetooth-enabled system, why they can basically share both their blood pressure and their blood sugar readings without a visit to the office, allowing us to monitor the patient more frequently, particularly with any type of change in therapy. Remote monitoring is a challenge with our population. We had actually had a study of health literacy within our population and recognized certainly that the older population were not going to easily adapt to sending information into an information system, albeit the patients were intrigued and enthusiastic about doing that, but learning those skills required additional effort on our part, and we've added community health workers to our overall clinical staff with a primary focus initially of setting up the monitors and being able to get information transferred to our care management system. The community health workers have tablets and are able to assist patients from their home to send data in if they don't have a smartphone or other communication device, and they also continue to do that until the patients are independent in learning how to basically send information. And we now have people in their 60s and 70s that are perfectly capable of sharing data in this method without any assistance as they adapted to understanding the value of this system. And this is an example out of CDMP of the blood glucose readings, and it's presented as a chart or a log that might be recorded by the patient if they were doing a home log with time of day indicated. And we can flip it over to a number of different graphic presentations. I'm just showing a couple of them here. With the patient in the office or the patient at home with a tablet and the community health worker, this visualization helps them understand their diabetes control. The other component within CDMP is the survey tools that were highlighted by Corey and our behavioral health activity, and having them computerized, I want to emphasize, allows us to actually score the survey tools, so you don't have to do a manual scoring and build information off of that. And we have several different diabetes surveys that we are able to use. The one we have up here is the Diabetes Distress Survey, which then can feed back into our diabetes education program and focus on areas that are of major concern to the patient. In the spring of this year, we had the opportunity to pilot a program with an organization out of Philadelphia, or outside of Philadelphia, ABC Diabetes, and they were wanting to have experience with CDMP, and we were able to connect through Zoom to have a diabetes educator provide care for 4 of our patients by having 5 educational sessions. With the educational session, both our providers and our community health workers gained understanding of diabetes education by sitting in with these sessions and working with the diabetes educator to develop a care plan. CDMP, as we've shown, is able to show the educator clinical relevant information and provide the results of the survey tools to the diabetes educator to help structure the educational program. And within that, why CDMP actually has a structured care plan, which is shared to all the members of the team. And with that experience, which was very positive, we had the opportunity just recently to contract with an APRN CDE that's on Oahu and is very experienced, and a dietitian. And so both of those individuals through BTC are joining our team and are focused on training our community health workers and additional staff in diabetes education and nutrition management. And they will also be able to provide direct patient education to our patients. The dietitian is also developing our recent our WIC program, which was recently awarded to LCHC. Just briefly to share the structure of the care plan, which is on the left, and also our dashboard, our snapshot, which is the clinical information that is nightly uploaded from the electronic health record and then restructured into a focused presentation, hopefully on one page, that the diabetes educator and other folks can look at and understand the various different aspects of the clinical metrics related to diabetes. We also have funding to take care of diabetes prevention, and the Department of Health here has been focused on that. This has been a real challenge for us because the desire is to have the use of CDC program, the diabetes prevention program, that is well structured and is well validated, but requires group participation. And with a small community of ours, why it's very difficult to have large groups. We just don't have that many patients or population. So we've looked at defining our population that has prediabetes, and has spent over a year basically identifying and testing people for prediabetes. But we certainly have a limited resource as far as introducing program development. And so we focused on the population that would greatest benefit from the program. The small population is a challenge, so we're developing, programs that are customized to individuals and small groups, understanding that 25% of our patients are foreign-born, and so we also have significant language and cultural issues in reaching this population. And as a health center and looking at quality, we've looked at long-term outcomes, morbidity and mortality, and so we attempt to put our resources where the patients will benefit the most. And this is a little bit difficult to understand, but it's our presentation for our population with prediabetes, and it's a rather interesting graph. Prediabetes and diabetes is usually associated with obesity, and so the focus of the diabetes prevention program is to lose 5 to 7% of a patient's weight, which decreases the chances of moving on to diabetes, and having 150 minutes of exercise per week, or 30 minutes a day of moderate to extensive exercise. And this chart, every dot represents a patient. And if you look at the BMI, anything less than 27 is actually a normal BMI. And you can see that our population with prediabetes has about a third of the people below the line. And this is a reflection of our ethnic mix, and particularly the Asian population, which often develop diabetes with normal weights rather than being overweight. The other thing with focusing on outcomes is that prediabetes, the patients slowly develop diabetes, and we can slow that process down, but not everybody with prediabetes gets diabetes the next year. It's a fairly slow and longitudinal process. And we're really talking about diabetes management to prevent microvascular complications of eye disease, kidney disease, and neuropathy. And those develop well after 10 years of diabetes. So when you're looking at a population over the age of 60, why they have comorbidities, and so you're trying to prevent diseases that might be 20 or 30 years in the future. And given that population, there's real value in doing diabetes education or prediabetes education, and the fact that people that exercise and lose weight often have increased quality of life. But most of the time, investing time in that will not actually impact the morbidities that are associated with diabetes because of the age. The other group is the people that are that have weight over the over 40 BMI, which are morbidly obese, and that's a special category of obesity, and it does not lend itself to weight reduction in large-term studies. So we have a population that's between the two lines and younger than 60 that are going to be our focus, and we're going to be working hard on those folks with a fairly traditional approach of educating them on lifestyle and exercise. And we've done a lot of talk about CDMP, and I wanted to give background for CDMP. The program was developed with a consortium led by the Joslin Diabetes Center that included the Boston VA, the military with Walter Reed, Indian Health Service, and the University of Hawaii and Triple Army Medical Center. And it was primarily funded by the Department of Defense, and initially developed the teleophthalmology program and subsequently added the comprehensive diabetes management program. That's involved into the chronic disease management program, so we could keep the same CDMP intact. And it's designed to complement the electronic health record and has interfaces with multiple electronic health records, including ECW, which is our electronic health record. And originally this was designed around the chronic care model, which really emphasized team-based care. Historically, it's really been primarily research-oriented with multiple published articles. But most recently, it also fits well with the CMS alternative payment mechanism with CPC plus Track 2 and is commercially available through Saturn Care. And I'm going to go back and just sort of emphasize what telehealth and health information technology has provided for our patients. We've focused on affordable and access to quality care for our patients, and that's clearly uses telehealth and health information technology. Our view has always been that technology supports high-quality care and does not drive high-quality care. There's certainly been expectation nationally that if we had health information technology, that would automatically improve health care, but it takes a lot of work to figure out how to use that effectively. The access to care does cost money, particularly in a rural setting, and clearly our teleultrasound and our teleophthalmology with the cost of the equipment will never be able to show a return on investment as far as paying for our efforts out of collecting money for the services. But it does significantly improve access to care. The telehealth, the travel costs and the telehealth savings are significant. However, the savings are primarily realized by the patient and not by the provider that provides the service, with the exception of Medicaid and occasionally other insurances where there's a health benefit that provides for transportation and off-island overnight stays, if indeed there's need for that. But very clearly, it also allows us to do very timely consultation, and the telehealth allows us to transfer that data to people to do the interpretation. Just a brief rundown of some estimates of our cost savings. Literally everybody has to fly or take a ferry to get to consultations. The primary source of consultations is Oahu, which is a plane fare, and ground transportation, and those run about $250 per case. And so looking at the ultrasound, we have a $28,000 saving for that. Teleophthalmology, looking at having them either see an eye specialist, which the exam for a dilated eye exam can run around $200. Our retinal imaging gets reimbursed at approximately $50, so that rather than having our optometrists having their rooms filled with people that don't need their services, why we can basically provide the retinal imaging at a cost savings of about $4,500. The telederm, again, is a consultation off island, and even though we don't need those services very often, there's another $3,000 saved for primarily our patients. There's a realization that Medicaid managed care plans, which is the service in Hawaii, do pay for the transportation costs for patients, but there is no mechanism currently to have the health center compensated for those services. And the cost estimates do not include the time off work, which is usually a day or sometimes two, the hotel accommodation, due to the limited flight schedules off the island, and often family members who have to take time off work to travel with patients. The other component that has certainly been challenging for a small health center, that is our rapid growth. And we've almost doubled the number of patients we're seeing in 2013. And our numbers just for hypertension in 2016 increased by 43%. We have introduced community health workers, and we still are looking at how to most effectively and efficiently use community health workers as have them start working with our patients that are in the community while we still have gaps where we're not reaching all the patients we need to. And then we obviously have the conflicting priorities as far as using health information technology. The community health centers have to do UDS quality metric recording. We've got meaningful use that we're involved with. We are part of the CMS Million Hearts research project. There's an alternative payment mechanism, and that has extensive reporting requirements. And then we've had staff training, and our staffing has increased from 14 employees to 40 employees since 2013. Clearly vertical integration has improved care with the support of the University of Hawaii, but we have programs with the VA, with Queens Medical Center. We are a Kaiser provider, and working out better integration with all of these organizations often requires contracts or collaborative discussions and introduction to that. Just yesterday, I got an invitation from the VA to start doing telehealth with their organization. And then as a small organization, we have very little influence over the partners we use, including eClinicalWorks, LifeScan, which produces a one-touch meter. We use the CVS blood pressure cuff Series 800s, and they've made it very difficult even just to purchase the units in bulk. And so these are all areas that have taken longer than would otherwise be expected if indeed we were able to work more efficiently with larger organizations. And with the introduction of the remote monitoring, we really are locked into one specific blood pressure cuff and one specific glucose meter. And one touch is covered by many of the health plans, but not all of them, so they require prior authorization. We've not had any problems in getting prior authorization, but sometimes it takes an appeal process before we can get it covered for patients. and then, you know, we are very much set up for alternative payment mechanisms with the types of services we have and the cost savings we have. But we do have small numbers, and it takes extra effort to basically provide services to small numbers of patients. And our technology is expensive because we're small, but it's fully scalable, and so we would look for being able to support this activity as these types of services expand, but it hasn't happened yet. And at that, I would want to say pau, which is the end in Hawaiian, and I want to express our deepest appreciation for HIMSS and this honor to be able to do this type of presentation and share some of the exciting things we're doing.
Thank you.
Well, thank you, and thank you both, Dr. Humphrey and Dr. Takasui, for the presentation. Just want to remind folks where to go find this recording and other Davies use case webinar and information on how to apply for Davies Award. That information can be found at the HIMSS Davies Award website at himss.org/Davies. And so thank you, and